Yeah, thank you. I think thanks to Nishikant, though he is not here. So, uh, I would be speaking to you on vitrectomy for retinal vasculitis. Here, the key consideration or the cornerstones of management in vasculitis is the diagnosis itself and the medical management, not so much in the surgical management. Surgery, if at all it's indicated, is you can do it only after you have achieved adequate immunosuppression in the perioperative period, and corticosteroids during this time is good. Surgery needs to be done only when there is a possibility of some visual gain. So the key is not so much in the surgery but in diagnosis and immunosuppression. Some of the indications would be vitreous hemorrhage, vitreoretinal traction with macular distortion, epiretinal membranes, tractional retinal detachment, and combined retinal detachment. The problems that we commonly encounter is there is macular ischemia because of the vasculitis, peripheral fibrovascular proliferations, frequent occurrence of vitreoschisses because they occur in the young, so PVD would have not occurred, and you need to support the vitreous base with a belt buckle. So in one of the papers that was published from PGI, they looked into what is the cause in the patients who underwent vitrectomy for retinal detachment, and they found that most of the patients were idiopathic, accounting for about 61%, remaining 27 were the tubercular or presumed tubercular. The rest of them were distributed between Behçet's, viral, presumed sarcoid, and syphilis. The indications were predominantly tractional retinal detachment and combined, and about 67% of those patients had vitreous hemorrhage. The gratifying thing is that improvement in two Snellen lines was seen in 70% patients, and the anatomical success ranged from 87% in the primary surgery to 91% in the secondary surgery. But the more important is to diagnose this condition and manage it well, because surgery does not give you that solution. So you need to do certain specific tests for SLE, like the anti-double stranded DNA, the ANCA for small vessel vasculitis, then the test for sarcoidosis, and certain serological tests to tell you whether it's a viral infection or toxo. PCR has added on to the diagnostic armamentarium, and you can come to a specific diagnosis, though false positives are known. In surgery, one of the things that we do is also to differentiate the cause. We do a diagnostic surgery, which could be in the form of paracentesis or a vitreous biopsy. So let's look into some of the cases. This is a 56-year-old gentleman who came with blurring of vision, 15 days, vision was 660. You can see that there is a vasculitis, there was macular edema. So this is how the wide angle fundus picture looked. We investigated, we found that Manto was negative, IGRA was negative, ANCA and ANA profile were negative, HRCT thorax was negative, HLA-B51 was negative. So most of the tests turned out negative, so we labeled it as idiopathic retinal vasculitis. Responded well to oral steroids and was on tapering dose, reached a vision of 618. We did a fluorescein angiography. One should remember that after vasculitis, do an FA, because that will show you the areas of capillary non-perfusion. So we did a sectoral laser. So 1 month post laser, patient came back with blurring of vision due to fresh hemorrhage. There was no fresh evidence of vasculitis. We did some more laser augmentation, but hemorrhage did not clear. It became worse, in fact, and vision dropped to 3/60. At this time, we could also see some ERM. So we initiated surgery. So these would be certain indications wherein surgery would be necessary. So you would see that most of them have multiple layers of membrane, so you need to dissect this. I use a pick to identify the membrane. So this is one step that you should always look out for. There would be multiple layers, and you can see that this is the ERM that was there, which was extending from the disc. So these are some steps that need to be done. And once you are able to release this, it tends to be easier to dissect the proliferation that is there around the disc and reduce the chances of future hemorrhage. Once this was done, we did an ILM peeling because there was the macular edema. So that this relaxes the traction that was there. I avoided going over the macula predominantly, but you can do completely once you went around it. And then shaved the peripheral base because they would have a lot of proliferation extending up to the periphery. And once this done, do a good laser, endolaser, and then just with air, I think they do very well. This is 1 week post-op. There's a small air bubble and vision had improved to 618 and patient has remained stable. So a very easy way to manage these cases. This is another 30-year-old gentleman who came with blurring of vision since 1 year. He has been treated with ATT elsewhere for presumed ocular tuberculosis causing retinal vasculitis. He had also received intravitreal ranibizumab for CME. When we saw the patient had a vision of 618, we could see NVD, and there was a cystoid macular edema. We did an FA and then we did laser to the areas of capillary non-perfusion, started on oral steroids, and then referred to the immunologist for immunosuppressive therapy. With immunosuppressive therapy, there was no fresh patch of vasculitis, and however, the patient had recurrent hemorrhage and it was not resolving. So we had to do a surgery in this situation. You can see the hemorrhage is very thick because it had been multiple times that the patient had bled. The biggest challenge is unlike diabetes, you have neovascularization going up to the periphery, so you have to be very careful while removing the vitreous because you would come across areas where there is proliferation and you could easily cause a break. So very gently one needs to keep dissecting and going to the periphery and remove all the hemorrhage. Because if you leave a large amount of hemorrhage, again there will be post-operative haze, so you have to go dissect. You have to identify the bleeders that occur and treat them. And cauterize them. So these are some challenges that we face. You go to with depression, you clear up as much vitreous as possible, preventing any further complications from occurring. This is 1 month post-op. Now the patient has a vision of 6.9 and has been on Azoran 100 milligrams per day. You can see the OCT shows a normal macula configuration and everything looks good. Patient is very stable now. This is a 60-year-old gentleman who came with blurring of vision 1 month, status post-laser for both eyes for vasculitis. Vision was 660. It responded to oral steroids, but vitreous hemorrhage was recurrent. Most of them do have this problem that there is hemorrhage which does not resolve because there will be multiple areas of vitreous traction that occurs and causes bleeding. So this patient too, we had to clear up the hemorrhage. Then identify there's always some amount of shitic vitreous, so you have to be careful in dissecting that because the areas of new vessels which are there and multiple in number would bleed. So you can see that hemorrhage is a predominant problem in vasculitis. See, we induce the PVD now, and once we clear the central area. So even if it is a 60-year-old, you would be surprised that most of them do not have a PVD, so you'll have to induce it. And once we do laser, this is 2 months post-op. Patient had a vision of 636. OCT showed cystoid macular edema, but with just subtenance triamcinolone it resolved. Now the patient has a vision of 612, normal macula. So key to management in vasculitis, is not so much in the surgery, but I think predominantly in proper medical management to prevent complications. Some of the common ones are the vitreous hemorrhage, which can be easily managed, and in tractional detachment, I think because the traction extends to the periphery, we need to put a belt buckle and support the base whenever you do. Rest of the steps would be very similar to any tractional detachment that you manage, including diabetic tractional detachment. So key is management, medical management with steroids and immunosuppressive therapy. The common problems are bleeding and the traction detachment, which is peripheral, so you needs buckling in this, generally in this patient. Thank you.
Thank you, sir. So, have you ever encountered patients like in these vasculitis? So, this the vitreous is too tightly adherent to
That's
these. Yeah.
Yeah. So that's what I was showing. The
Yeah.
vitreous, the removal of vitreous is the key to the whole thing. That
Yes.
is, it's always, there's shitic vitreous
Yeah. So
and it is attached to multiple points
multiple
like this. So when you do, you'll get bleeding.
breaks also
Yeah, and
sometimes.
you can also cause breaks. So you have to be very gentle in
Legend. And
removal.
sometimes you just have to trim the vitreous around
And
them.
around that, that's what,
Yeah.
like what we do in diabetics sometimes when it is thickened and
Yes.
we just leave one small island of
Yeah.
membrane
Yes.
there.
Yes.
But bleeding and this problem is very well known.
Yeah. And many of these cases are chronic, and they do have those dry folds also, which you can't settle them.
Yeah. So these are, that's why, so if it goes more to the periphery, best is to buckle them
Buckle
and,
them,
and
yeah.
try to support it, because you cannot, address it so aggressively.
Yes.
And, but I think the key is, if you get the patient managed well medically, then surgery is simpler. If they are not managed well, they give a lot of problem future.
So in these cases, do you give pre-op anti-VEGF or steroids or something like that?
This, no, I would rather give steroid for them.
Yeah.
I keep them on, although they are on immunosuppression, just step up the steroid dose for that period and then again bring it down after post-surgery.
Right.
So let's say they are on maintenance dose of 5 milligram or 10 milligram with immunosuppression. You step it up to 40 and do the surgery and then again start reducing it.
Yeah.
That's a...
So any further questions?
Vasculitis, steroids is a better option than doing with anti-VEGF, no? Because it's a inflammatory component that drives it. No, someone has given, because they saw a cystoid macular edema treated elsewhere, they observed a cystoid macular edema. It doesn't work. But they had thought probably that it is tuberculous vasculitis. They were thinking in terms of, in tuberculous vasculitis and tuberculous etiology, granulomas, I know that anti-VEGF works, but I'm not sure about vasculitis. I would rather treat them with steroids. That's, we actually manage them with steroids rather than with anything else.